Services. Happy Juneteenth. I see that the attendance is fairly low today. We tried to get word out that we would still have the forum today. And partly we wanted to go forward today because we will be talking today um, um, about the American Rescue Plan Act and our plans there. And as you'll hear, we have a limited amount of time to submit our plan for approval to the Centers for Medicare and Medicaid Services. So I wanted to make sure that we could present sort of the draft of where we are so far today, and still have an opportunity next week for people to give us whatever additional input you might have. So I will start today, as we always do, by reviewing our data, which I'm glad to say has not changed except for as it relates to the vaccination data, has not changed since last week, but I'll go ahead and share my screen. Are people able to see the slideshow? Because it's showing up funny on my screen right now.
Yes, we can see it on.
Great, thank you. So as I said, no change. We still to date have 429 people who have tested positive for coronavirus, none so far in the month of June. The last person was in May, about the middle of May, May 12th. By COVID infections by placement type, 9 in host home, 114 in intermediate care facilities, 1 in a mental health facility, 56 in natural homes, 2 in a nursing home, 4 in out-of-state placements, 37 in residential habilitation, and 206 in supported living. And so by placement type, those 114 in ICFs represent about 38% of people in ICFs who have contracted COVID. Of those, there have been 24 who have died, but only 13 of those are confirmed as COVID deaths, representing about 11.5% of people with COVID in ICFs who died from a confirmed COVID death. In natural homes, the 56 people who contracted COVID represent about 6% of people in natural homes. Of those, 5 died, and all 5 are confirmed as COVID deaths, representing about 9%. Within residential habilitation, the 37 people who've contracted COVID represent almost 34% of the people in residential habilitation placements. 3 died, but only 2 were confirmed as COVID deaths, representing a 5.4% death rate. In supported living, 206 people contracting COVID represent about 22% of people in supported living placements. There have been 21 of those people have died, but only 15 are confirmed COVID deaths, representing a little over 7%. So overall, the 429 represent about 18% of people supported by DDA who've contracted COVID. Of those, there have been 37 confirmed COVID deaths, which represents 8.6%, and a total of 57 people who had COVID who have died. And as I indicated, there have been no COVID infections reported this month, and so in the month of June in all placement types, of course, it's 0. And similarly, no one, of course, required inpatient treatment, and there is currently no one in the hospital requiring treatment. So there are a total of 57 people who have had COVID who have died. Most recently in May, there were 2. We have now had 14 of the 57 that have been confirmed as not COVID related. And for 6, we're awaiting the confirmation from OCME regarding the cause of death. Which is 37 people who have died from confirmed COVID related deaths, the most recent being in March of 2021. And among our provider staff, we also have not had any new COVID infections this week. So there have been a total of 697 provider staff who've tested positive for COVID-19, 51 of whom have worked for more than one provider, and 10 staff who have died from COVID. The vaccination rates among the people supported by DDA, it's at 74%. Within host homes, it's at 70%. In intermediate care facilities, 96%. In natural homes, it's at 56%. And residential habilitation is at 92%, supported living at 83%. Among provider staff, we haven't yet posted it on our website. We will be doing that soon. We've updated that. It's now at 56%. So I'm going to stop sharing for a moment just to see if there are any questions about that, and then we can talk about the American Rescue Plan Act. Okay. So as people, I believe, are aware, the American Rescue Plan Act was signed into law in March of this year. And it has enhanced Medicaid funding for home and community-based services. It provides the opportunity and potential of up to a 10% federal match, that it's referred to as FMAP, the federal match for our Medicaid services, for services provided between April 1, 2021 and March 31, 2022. With some provisions, including that the new funds must supplement, not supplant, the level of state funds for the program that were in place on April 1, 2021. The eligibility for enhance requires the states to enhance, expand, and strengthen home and community-based services through the Medicaid program. In 2024. So we have to have a plan this year, and we get a 10% bump this year, but the funds need to be spent by March 31, 2024. Still an open question whether spent means spent or allocated, but at least we do have beyond the March 31, 2022 deadline. And we are currently working with DHCF and DBH on plans to utilize the funds here in the district.
Excuse me, Director Reese, I can't see whether your slides are advancing or not. I just see, okay, there it is.
So states can spend funds attributable to the increased FMAP on home and community-based services and related administrative activities. So it's a variety of things that we're allowed to spend funds on. Increase in the amount, duration, and scope of services, new or special provider payments and rate enhancements, provider workforce training, recruitment, or support initiatives, quality improvement measurement or oversight initiatives, information and technology implementation, strengthening assessment practices, changes to streamline eligibility, expanding the use of technology and telehealth, conducting care surveys, addressing social determinants of health, and enhancing care coordination infrastructure. So it is very important that, while there are a variety of things that the funds can be spent on, there are some rules about how that occurs. And they really emphasize it is supplementing the current system, not supplanting the level of state funds currently allocated. And there are a number of requirements that include you can't impose stricter eligibility requirements, methodologies, or procedures for the home and community-based services programs and services than what was in place April 1. You've got to preserve covered services, including the services and the amount, duration, and scope of services that were in effect April 1. Maintain provider payments at a rate no less than those in place April 1. And states are expected to retain temporary changes made under the Appendix K for as long as allowable. And they included that to be clear that if there are enhanced payment rates included in the Appendix K, if those sunset because the Appendix K has ended, that does not count as a reduction. So those reductions are allowable, but anything that's essentially it's a maintenance of effort requirement, and anything in place April 1, 2021 must remain in place, other than those temporary measures that were put in place through the Appendix K. So we have to submit both an initial and a quarterly spending plan and a narrative that describes the activities that we intend to implement. And CMS will share each state's summary publicly. The initial spending plan has to estimate the total amount of funds that are being attributed to the FMAP and the anticipated expenditures on the different enhancement activities. The initial narrative has to detail how the activities will enhance our home and community-based services waiver and explain how, and this is very important, explain how those activities will be sustained past 2024. Because anything that we put in place with these funds, and this is what I've talked about before, about the challenge of these funds, is that you need to know beyond the sunsetting of the ARPA funds, how the state will maintain any enhancement that's put in place. And that needs to be included in our plan. So the quarterly spending plan would include estimates by the quarter about the total of amount of funds that have been used that the state will be claiming through March 31, 2022, as well as actual expenditures on enhancement activities. And the quarterly narrative has to provide an update, a progress report on all the different enhancement activities. We're also allowed in those quarterly reports to make amendments to our plan. And there's initial and ongoing plans that include an attestation from the state that we're not supplanting existing state funding. So DHCF, which is the state Medicaid agency and is responsible for submitting the plan to the Centers for Medicare and Medicaid Services, is coordinating with DBH and DDS to finalize the scope of the activities. We're well, we're meeting together to plan what the city's approach will be. And in developing that plan, they have to consider the impact on the local budget, ensuring cost neutrality. They've got to consider long-term sustainability of any initiatives funded in the time-limited enhanced FMAP. So as I was saying, anything that gets put in place now, we have to have a plan for how it will be funded after these funds have been exhausted. And also we'll be considering equity of enhancement activities across the different programs and providers. DHCF will have ongoing discussion with the Centers for Medicare and Medicaid Services regarding any programmatic requirements. The district did request initially the plan that we were only given guidance about 3 weeks ago. The initial plan would have been due by June 12th. The district requested and received an extension to July 12th. So our plan is now due to the Centers for Medicare and Medicaid Services on July 12th. And CMS has told us that they expect to review and approve plans within 30 days of initial submission. Our most recent Appendix K amendment is going on day 80 something with CMS. I hope that they are able to stick to this 30-day timeline. So I was happy to see that several people included in their testimony before the DC Council suggestions for activities or initiatives that we could engage in using these enhanced FMAP funds. I think that I've collected all of them here, kind of grouped them together, because different people were making some of the same suggestions. So first, funding best practices to increase vaccinations among DSPs and people supported by DDA. Survey of access to technology, as well as improving access to technology. Implementing self-direction. Expanding telehealth options and virtual health beyond license placements. And fund the DSP Payment Rate Act. So as I said, we have been working with DHCF on developing a draft of our plan, and I just wanted to give people a sort of overview of where we are so far in our thoughts about what would be included. It occurred to me, one thing that is not included here is that we have been working with DBH and DHCF looking at some things we could do to strengthen behavioral health services, but we don't yet have sort of it's not far enough along to be a draft yet, so that's not included in this list. But everything else that we've been looking at includes doing a whole lot to enhance the waiver technology supports. Including technical assistance, purchasing equipment, having the kind of support that people need to use the equipment, conducting the kind of assessment that people talked about in terms of what people's needs are. This is a real opportunity, and these funds really, this kind of initiative is the sort of thing that I think these funds are ideal for, because it does require an initial kind of huge infusion of resources. And so we hope to make some real progress on our on our technology supports for folks. As people noticed in our budget hearing, we talked about the urgent care telehealth services. So we'll be issuing a solicitation soon for a provider to put that in place so that we can implement essentially telehealth urgent care for people in an attempt to reduce emergency room visits as well as emergency inpatient hospitalizations. We will be starting with the licensed placements, including ICF and residential habilitation. Because of the timing of this, given the ARPA funds restrictions, what we want to do is see how that works and then roll out beyond the ICF and ResHabs. to supported living. We also thought this would be an ideal time. There'll be resources available to do a waiver rate study to look at a number of factors in our waiver rates. We are really interested in hearing more from people about what kinds of vaccine incentive payments might be useful in encouraging people to get vaccinated. I think based on our numbers, people have pointed in the proposals from people in the testimony, they said people we support as well as staff. And, you know, it is interesting to note that the people we support in natural homes vaccination rate is right there where the staff vaccination rate is. So I think looking at both of those probably makes good sense. We are also proposing a housing counselor position within DDS operations so that we would have a person who could help people to maximize the use of public benefits for folks in obtaining housing. We're also looking to study health effects of COVID on people supported by DDA, looking both at what we've seen in the past year. I know in tracking like flu, they talk about excess death, and that's how they determine sort of a death rate from flu, because not all people have, in the same way, not all folks have on their death certificate that they died from COVID. But we want to take a good look at the deaths among people during the first year of the pandemic, essentially from March through March 20 through March 2021, as well as taking a good look and some kind of survey of the 429 people who've contracted COVID and what the outcomes have been. And we hope that this will inform us on keeping all of our folks healthier as we move forward. And then lastly, it's not required to be included in our plan, but the American Rescue Plan Act did include an allowance for us to have a new round of retainer payments for day service providers. And we had a meeting yesterday with day service providers to talk about the best way to implement those retainer payments, what might be the most useful in terms of sustaining the viability of those programs as we move toward our reopening here in the district. So that is a pretty quick summary. And now I'm really interested to hear any additional input that people have, as well as answer any questions. First of all, will the PowerPoint be shared? Yes, both of the PowerPoints from today will be posted on our website they're usually posted on Monday. Does studying the health effects of COVID on people supported by DDA include hiring clinical staff to work individually with people who have tested positive to track their health and long-term effects and take appropriate action? I hope this isn't just a survey. So it's somewhere between those two. What you've described here sounds like sort of hiring a second physician for the person to work directly with them and to work with them over time on their health, as opposed to having a sort of really well-informed medical survey of the record of people who've had COVID so that they can identify what the effects were, if there are longer term effects, and to be able to provide input on the recommendations about treatment going forward. How much money will DDS be receiving for the IDD and IFS waivers through this FMAP bump? It doesn't work in that manner exactly. What happens is that you are allowed up to a 10% increase in the federal match. And so we will submit a plan to the Centers for Medicare and Medicaid Services. And if we spend up to 10% of what the total cost of our waiver services is in a year, then our federal match will be increased by that amount, and our local obligation for the waiver will be decreased so that it will free up the funds to pay for these initiatives under the ARPA plan. So it's not exactly like we're getting funds from this bill, but that funds are available, we can spend and then get reimbursed. Can you explain more about what the housing counselor would do? Yeah, so, and these are kind of initial thoughts. Working with people who have the potential to be living more independently, help them to identify the resources in the city, connect them with generally federally funded, publicly available resources so that they can live independently. We would, of course, continue providing waiver services to them, but this way, rather than using local funds to pay for their housing, we would be connecting them to available housing resources. Just a reminder to people, if you are asking a question, make sure you scroll down to everyone to ask the question, because if you send it to all attendees, everyone who's listening knows what your question is, but I don't. Will the COVID health study include a study of the impact of the pandemic on mental health needs? We were not thinking of that, in part because it seems to me that's a separate question, in that we are not looking at the 2,400 people supported by DDA or the 1,800 and some people in the waiver. We're looking at people who died during the year from any cause, as well as all people who had COVID. And so I would think that any look at mental health needs would be sort of a separate thing that would look at all the people we support. Although it isn't, I will take that as an interesting other suggestion that we could also look at. Will the plan submitted include the bump for DSPs? We have not included that in our plan. And the reason for that, as I had said, one of the things that we have to do in our plan is have a plan for sustaining the funding. And there isn't currently, beyond the 2022 or 2024, there isn't that additional bump. It would, based on the estimates that were done by OCFO when the DSP Payment Rate Act was passed, it would require an increase to the total DDS local budget of about 5% to cover the cost of that rate increase, just for that piece. And so, at this time, we don't know where those funds would come from. One thing I should say is, and I didn't include here, so in 2021, DHCF had an enhancement for 1 year for 1.4 million for bonuses for DSPs, and we're going to extend that for another year. So that is included, but that isn't an ongoing wage increase. It would be the exact same bonus that's included that was developed recently by DHCF. As part of the health study, will you be examining more closely the deaths of the 20 people who died after testing positive for COVID, but were found to have a cause of death other than COVID? We'll actually be looking at all deaths that occurred during that period of time, because my concern would be, the other health effects of that occurred for folks from spending a year I always blank on that word that Winslow uses. That means you're just sitting around all the time. But the real cost impact on your health of not getting regular exercise, of having more difficulty getting to the doctor. So we want to look not just at those 57 people, but at all of the people who died between March 2020 and March 2021.
Hazards to immobility, Director Reese.
Thank you. Do we have proposed amounts that each initiative would cost? We are costing those out now, so we don't have that yet, but we have to submit that when we submit our plan, so we will be submitting that. So the slide indicated that we would implement self-direction in the IFS waiver. What about the IDD comprehensive waiver? Our thought is that we would roll out self-direction in the IFS waiver. There, in rolling out a new service, we want to have it done in a way that's sort of a pilot, that's a smaller group, that we would really be able to identify what kinds of challenges you have as it gets rolled out, making sure that the rollout goes smoothly, and then look to rolling it out across both waivers in the future. And then Robin Schaffert from the USAID is just indicating, I think exploring and addressing mental health impact of COVID should be a priority. I agree, that's noted, and I think we'll look into, as I did say, we are looking at behavioral health supports, but I think COVID specific and generally to everyone would be a good thing for us to take a look at. I think you should also hire or contract with clinical staff to work with providers to provide TA to address long-term physical and mental and health effects of COVID. So what we're hoping is that the study that we will be issuing a solicitation for will make recommendations, and then we will follow through with whatever those recommendations are. For the telemedicine that was mentioned, how does DDS see this happening? Partnering with a telemedicine group or something different? Yes, we would issue a solicitation. I am aware there are, I think, 4 states that have implemented this urgent care telehealth program. And so there are provider groups out there that do this, and provider groups that have specific expertise in providing medical care to people with intellectual and developmental disabilities, which is part of how in those states they have seen such success in reducing the emergency inpatient hospitalization, because they do a very good job of assessing and very often being able to provide treatment rather than have the person go to the emergency room, where oftentimes in an abundance of caution, the person gets admitted for observation. So we do seek issuing the solicitation to identify a group that could provide that service. How many people are in the IFS waiver right now? 0. Actually, so right now there's no one enrolled in the IFS waiver. It would seem difficult to pilot self-direction. This might encourage people, because they would be allowed, if they so chose, to transition from the IDD waiver over to the IFS waiver, because they could access self-direction there. And the cost, the amount of services, the number of services, all of those things are, when we developed the IFS waiver, we looked at utilization in the IDD waiver. So there really are opportunities for a number of people, if they were interested in self-direction, to transition over. Someone just seconding how crucial it is to look at mental health effects of the pandemic on the people supported by DDA. And then expressing that people in the comprehensive waiver should be able to access self-direction too. And we agree with that, but we would like to roll this out in a more planful way, so that, as I say, as it first rolls out, there are a lot of things to work out. We learned that from when self-direction was rolled out by DHCF in the EPD waiver. And so we think that doing it in steps will be a more orderly process. Can we say more about the end goals of the technology initiative? I just wanted to see if, and Donald's not with us today. Can I punt to you, Crystal? Because this is really one of our more comprehensive initiatives in within the ARPA funds. And I think that you would do it more justice than I would, if you don't mind. Crystal, if you are able to unmute and respond.
I'm sorry, can you repeat the question? I stepped away.
So the question was, can we say more about the end goals of the technology initiative? And I think it's really 3 initiatives. And I just thought you could do more justice to explaining comprehensively all of the different pieces of those initiatives.
So the hope is to increase capacity within the entire network that we have. So folks that we support with DDA, starting even in the ISP process, having people be assessed for the appropriate technology that will allow them to live more independent in the community. Supporting providers so that they have the capability and knowledge of using remote supports, and supporting folks. Andy mentioned the telehealth piece with urgent care. But as a whole, all of us, and currently right now we have a shift program that we're basically just learning together with how to use technology or support people in accessing technology so that they can live their best lives. I'm trying to think of any other components within that. I think that's it.
So someone just agreeing that if you want to know about the challenges of a self-directed waiver, you should open it up to IDD since there's no one in the IFS waiver. As I said, folks in the IDD waiver whose utilization is below the cap on the IFS waiver might wish to transition to the IFS waiver. Once an organization achieves Tech First accreditation, what are their tech-related waiver services they will be able to provide? I'm pausing to allow Crystal to answer that in case you didn't notice.
Well, with the accreditation, it is, well, what we've noticed during this time is really just how important technology is. So the accreditation is that particular organization having them go through the curriculum, which again teaches folks how to assess a person so that they have technology that is supportive of their individual needs. And so that particular organization will be trained and And so that's that sort of accreditation stamp that we have. So you have DSPs and other folks that go through the organization, and so that they can continue to I'll stop right there because I don't want to say too much about it, but that's pretty much it. And DDS as well is going through the same process along with the providers.
Because, you know, one of the real benefits of the ARPA funds is it's going to allow us to purchase technology. But what is essential is that we don't have, you know, shiny toys sitting in the corner. It's essential that providers know how to use that technology so that they can help support people to use the technology so that it actually does promote more independence amongst the folks we support. How long do we plan to pilot self-direction in the IFS waiver? How many people need to participate for us to feel that we've evaluated it? And this person, Robin Chafford, also supports having it in the IDD waiver. The IDD waiver renewal occurs in November of 2022. So that's pretty much 1 year after this will be implemented in the IFS waiver. And that seems like a reasonable amount of time. We had anticipated putting it into the IDD waiver at that time anyway. So it most likely, my guess is that that's the way it would roll out. This also gives us a lot of time. You know, we'll start planning for that waiver renewal sometime early in 2022, and it will give us a lot of time to discuss, you know, all aspects of the waiver, including any preliminary information we have from our waiver rate study. So I don't see any other comments at this time. Let me just say, as I said, we will be posting the PowerPoint, I expect on Monday. And just for as a refresher of everything we've gone over today. And people can, you know, think about all of this over the next week, give us additional suggestions you might have, as well as any feedback on the draft plan we've presented so far. And as we have more specific information, we'll share more specific information. For any folks who are members of the MCAC, which I believe is it's advisory committee at DHCF. I'm trying to come up with what the MC would be.
Medical Care Advisory Committee.
Okay, Medical Care Advisory Committee at DHCF. There will also be a presentation at their next meeting about the ARPA funds that will address, you know, all ARPA funds, not just DDS, home and community-based services waiver specific. So thanks for your feedback on where we are so far. Will we be getting input from Project Action? I will be talking about this with Project Action tomorrow and just giving an overview on what our plans are and asking for their input. And as I said, postponement of implementation of self-direction in the comprehensive waiver seems like a lost opportunity for using FMAP funds. You know, the way self-direction is designed, it's supposed to be cost neutral, which is the reason that we want to roll it out in a very planful way to make sure that it is in fact cost neutral. And so if we do it on a smaller scale initially, we'll identify the areas where that cost neutrality fails so that we don't run the risk of doing that on a broader scale. There are lots of sort of protections within that that's supposed to prevent it from running over cost or from someone spending up their whole budget immediately. But we want to make sure that we're rolling it out in a planful way so that we really have the protections in place so that it does get introduced well, that it really has a good rollout that allows people to access it and that they can access it effectively. And if it is if it's operating the way it's intended to operate, and people have given us, it's really pretty ready to go, then it doesn't require FMAP funds. Quite frankly, it should not require any additional funds. I see some suggestions about how to implement it in a limited way within the waiver. It is a limited service within the waiver anyway. It is only for particular people in particular kinds of placements, and so it is limited. It's not available to everyone in the waiver. But we do have everyone's comments and feedback, and we'll be considering that as we move forward with our plans. And as I said, anyone who is in the IDD waiver, if they're getting in-home supports and they're under the current cap, they could just as easily transfer to the IFS waiver to benefit from that service that's in IFS and is not in the IDD waiver. Isn't one of the reasons self-direction was postponed originally was because of the startup costs? No, actually, it wasn't the startup costs. It was the uncertainty of the costs as you get started because you're starting a brand new program. The cost of it is, there's already a contract in place. We would ride on the contract because the number of people served wouldn't justify having our own provider for self-direction. We would use the provider that's used by the EPD waiver. And so they're really, in terms of startup costs, there aren't. The concern was starting a brand new service where we're going to have these challenges at the beginning, making sure that we are controlling the costs the way they are intended to be controlled as self-direction is written in the waiver. Those uncertainties in May of last year were scary. And, if you go back to May of last year, we were in a pretty scary place fiscally. So that was the reason for not rolling it out last fall as we had intended, just because of these uncertainties. And it's because of those uncertainties that we want to roll it out in this more planned, small way to make sure that we address any of those issues up front. Okay, well, thanks to everyone for all of your input today, for the suggestions that you made at the budget hearing as well. And we have all of your comments from today. We'll be considering those. And as I said, we'll have next Friday for people to mull this over a bit and provide any additional comments to us. The district's plan is due to CMS by July 12th. DHCF is hoping to submit it prior to that, so they'll be looking for us to get our plan to them relatively soon. But I think it's very reasonable for people to have until next Friday to give us any additional input that we could consider. And as I say, as we have more specific information about the plan, we will share that as well. So have a great weekend, everyone. Happy Juneteenth Day. That's a holiday that has existed for many people for a long time, but sprang up as a federal and district holiday pretty quickly. So I'm glad for the folks who were able to join us today. And I hope that you enjoy the rest of your day. Thanks.